It's really common for people to attribute all sorts of things to anesthesia. And it's important to know that every drug, as you well know, has a half-life, which means that's the time it takes for the body to reduce the amount that's in the body by half. And over the course of a certain number of hours, all the drugs wash out of your body and you kind of return to your ordinary state. And that's why usually we say don't do anything. Don't make any medical decisions. Don't make any financial decisions for 24 hours. Don't drive for 24 hours. Wait until tomorrow before you start resuming your normal activities. And of course, follow the surgeon's post-operative instructions.
Hello, everyone, and welcome to Finding Your Wellness, podcast sponsored by the Columbia Association. I'm Dr. Harry Oken, a community physician for over 35 years and the medical director of the Columbia Association. I am proud to be working with Columbia Association for over a decade to help assist in their mission to improve the health and wellness of our community. Today, we're going to talk to a new member of the Medical Advisory Board, Dr. Stuart Roth, and our topic is myths related to anesthesia. Let me first tell you about Dr. Roth. He was born and raised in Allentown, Pennsylvania, and he did his undergraduate studies at the University of Pittsburgh, and then went to graduate school at the West Virginia University and got his PhD in clinical psychology in 1978. He practiced in the community medical center until about 1980, and then he had a joint appointment in the Department of Psychiatry at Marshall School of Medicine, and he practiced then until about 1982, when he was then admitted as a medical student. He did his anesthesia residency practice in a variety of places, but he did his anesthesia residency at the University of Maryland, my alma mater. He also worked at St. Agnes and finished up his career at the Good Samaritan Hospital. He's been retired from anesthesia since 2023, and his clinical practice involved caring for patients as young as neonates and as old as centenarians. So welcome, Stuart, and thanks for doing this.
My pleasure, Harry.
So anesthesia is a medical intervention that prevents patients from feeling pain during procedures, typically surgery, but all sorts of procedures. An anesthesiologist is a doctor that has been specifically trained to give medicines used during these procedures. So today we're going to talk about the different types of anesthesia and the worries that people might have about undergoing anesthesia. So when somebody has a procedure, they often, after the nurses are finished with them, when they're getting ready to have the procedure, they meet generally you.
They do.
Have a lot of anxiety, don't they?
Oh, yes. Anxiety is pretty much to be expected prior to any surgical intervention. It's always a trip into the unknown for the patient.
And so you probably, with your background of being a psychologist, you're more critically aware of it than probably most people, right?
No, it's entirely possible.
Yeah. So what's your approach?
The first thing I do is introduce myself and make sure that they know who I am and what I'm there to do, and then review their medical history with them. And in doing so, I get a sense of how they're coping with their anxiety. Some people want a lot of information. Some people prefer to use humor. Some people are almost mute with their unwillingness to deal with what they're about to experience. And I do my best to prepare them and let them know step by step what they're liable to experience. And then during each step of the procedure, explain what's going on so that they have a sense that they've already been prepared for it.
I guess if they're having general anesthesia, one of the worries is, how do you know I'm going to wake up, doc?
Yeah, well, luckily enough, people usually wake up. As a matter of fact, in 30 plus years, I haven't never had a patient that didn't return from their anesthetic. You know, it's a reversible process with drugs. We may not know exactly how they work, but we know what their time course of action is, and we can time their awakening pretty successfully.
What else do people worry about with anesthesia?
Particularly older people worry a lot about whether it's going to cause them to deteriorate mentally. And it's true that as we age, the risk of having a problem, the medical term is delirium, where they have a difficulty understanding what's going on. They tend to lose their ability to know where they are and all the rest of that. And that turns out to be a real harbinger of problems later. In my experience, it's usually older patients, frailer patients, and patients that already have other problems that the anesthesia kind of unmasks for them.
We have a name for that, right? Post-anesthesia cognitive dysfunction. Yeah.
Yes.
Yeah. And we've seen it, and hopefully it's short-lived.
Well, yes. And as you well know, the short-lived version is delirium. The long-term term for it would be dementia.
Right.
And my experience is that people don't develop dementia as a consequence of anesthesia. Many people have problems that are kind of masked because they live in their normal state. They're in their normal environments. Once you take them out of their normal environments, scramble their brain with the anesthetic drugs, and then insult their body with a surgical procedure, that tends to unmask the underlying cognitive dysfunction.
Yeah, and I think that's a good point, that just about any invasive procedure does cause a systemic inflammatory response at some level of some magnitude. So there's always going to be that and the recovery from that. But also, to your point, it sounds like people who experience post-cognitive anesthesia dysfunction probably already have some level of either recognized or unrecognized cognitive impairment.
For certain. I read a paper this week suggesting that sleep disturbances often herald a potential problem with delirium. And all these things are probabilities. No one can say as of yet for certain what causes or doesn't cause it. We can say that certain things are associated with it. Sleep disturbances, frailty.
And so in an older person preparing for surgery with that anesthesia, and here we're really talking about general anesthesia, but we'll talk a little bit about monitored sedation and regional anesthesia in just a minute.
Sure.
Do you have recommendations for that person getting ready for that surgery?
There's actually a term for it called rehabilitation. And, the things to recognize are the things that we would say for anyone. Get plenty of exercise. If you smoke, stop smoking. Get adequate nutrition. Get adequate sleep. All those things. Get to know talk with your doctor or with your surgeon about what the surgery is going to entail, what the plan for recovery is. All those things get you in the proper mental state for what's to follow.
I think it's really important before patients go under a major surgical intervention where they're going to have general anesthesia, that there's a really good review of what medications and supplements they're taking.
Absolutely. The sort of lay term for all that is for someone to be cleared for anesthesia.
Right.
But realistically, what we're talking about is medical optimization, seeing your primary care physician, reviewing the medicines, making sure that what things can be optimized. And that's where the primary care physician comes in, Harry, as I suspect you know all too well.
Right. Yeah, the concept of clearing somebody for surgery is such an old concept. My role is to identify the risks for surgery and be able to counsel the patient as to, are the risks acceptable?
Yes.
And we have obviously a number of different ways of actually doing that and statistically characterizing them where they fall into. And of course, some people, no matter what the risk, need the procedure, and we're going to accept those risks, but at least we know about them going forward, right?
Exactly.
Yeah.
Exactly.
Yeah.
One of my professors in my residency used to say that one of the potential risks is death if you're willing to understand that that's the case. Of course, that's pretty extreme, but it's true.
Yeah.
I've had patients who say, I can't live like this. I need to have this done regardless of what the outcome is.
Sure. I'll take my chances, Doc.
Yeah,
Right.
Exactly.
Right. So are there any things that you wanted to tell the listening audience about myths related to general anesthesia?
I think that it's important for the patients to know that during the procedure, the whole team in the operating room is functioning, doing what they're doing. If you watch TV, it always seems like the surgeon is barking orders at the anesthesiologist. And in fact, it goes both ways. Sometimes you have to tell the surgeons to stop doing what they're doing, and so you can catch up either with the blood loss or with the muscle relaxation or some of the other things. Everybody has a role and everybody is functioning at sort of at the top of their game during a surgical procedure.
Yeah, it's the anesthesiologist or nurse anesthetist is so important in making sure that there's going to be a great outcome. I didn't tell you this, but my daughter is a nurse anesthetist, and I talk to her about this all the time. Now, post anesthesia.
Yes.
Thoughts and comments for our listeners?
It's really common for people to attribute all sorts of things to anesthesia. And it's important to know that every drug, as you well know, has a half-life, which means that's the time it takes for the body to reduce the amount that's in the body by half. And over the course of a certain number of hours, all the drugs wash out of your body and you kind of return to your ordinary state. And that's why usually we say don't do anything. Don't make any medical decisions. Don't make any financial decisions for 24 hours. Don't drive for 24 hours. Wait until tomorrow before you start resuming your normal activities. And of course, follow the surgeon's postoperative instructions.
Yeah, I think that's really important. Everybody always feels fine after their colonoscopy, right? And they can drive home. And yet we know that the propofol that's used often is still in their system, even though you might not feel it is. Which brings me to the monitored sedation that anesthesiologists and nurse anesthetists do.
Yes.
Talk a little bit about that and explain how that's done.
Well, the basis of doing anesthesia is to make sure that the operator, the surgeon, the gastroenterologist, the cardiologist, has the best possible conditions for doing their procedure. And for something like surgery, there's a great deal of pain involved. So you have to use appropriate medicines to reduce the pain. It could be regional anesthesia. It could be a general anesthetic. It could be an opioid pain reliever. All those things are possible. For something like a colonoscopy, where the pain it's probably as intense as gas pains that you might get sometimes. So the amount of pain medicine necessary is little to none. So the things which cause people to lose consciousness, particularly propofol, washes out of their brain very quickly. It's why they feel really wide awake afterwards, even though, as you point out, the body is still metabolizing the drug and it still has some effects afterwards. We do, for example, podiatry. A lot of people have bunions and get bunion surgery, and that's usually done with sedation. The most painful part of it is getting the local anesthetic in your foot beforehand. Once that's in, you can kind of sail through with a relatively minimal amount of surgery. And I always say that a well-prepared patient can tolerate almost anything. So if the patients know what's coming, they can deal with it. Some patients are happy to be awake and just kind of relaxed. Other people prefer to be completely asleep, even though that sleep is different than it might be for a more invasive procedure.
Yeah. Circling back a little bit more to general anesthesia, there was something I wanted you to talk about, and that was a lot of times with abdominal and GYN surgeries, post-operatively, people will experience a lot of GI issues. Their colon, their small intestine is slowed down. But recently, there's been some really good advents in the approach to how people are actually given general anesthesia and bowel and attention to the bowel to minimize that dysfunction.
As again, I'm sure you're aware, one of the mainstays of postoperative pain relief is our opioid drugs. Opioid drugs almost universally cause constipation. That makes things really difficult. There are a variety of ways of doing that. With the advent of the opioid crisis in our society and the fact that medically prescribed opioids are often the beginning of a problem with them, we in anesthesia have worked toward reducing our use of opioids. One way of doing that has been to use other drugs. There's certainly intravenous drugs in the same class as ibuprofen. Ketorolac is one of them. We can use that. Regional anesthesia has exploded in recent years with the advent of ultrasound-based nerve blocks. And we've moved from using regional anesthesia in close to the spinal cord to away from that using local anesthesia around nerve bundles, even further, where we can go in between layers of muscle and catch the sensory nerves and have less disc and have a significant effect on pain relief while still reducing the kind of numbness and tingling that people often get after a nerve block.
Right. So the regional anesthesia development, as you said, are being used more and more. And that was one of the things that you did quite a bit of
I did.
Yeah. And so here's some questions for you. I've seen regional anesthesia used in a whole variety of different, particularly orthopedic procedures.
Yes.
And one of the most painful procedures post-operatively has classically been repair of a rotator cuff.
Yes.
And what I'm seeing presently is a lot of regional anesthesia that not only, you're able to do the surgery under regional anesthesia, but post-operatively, in some instances, the regional anesthesia can continue for a given period of time.
Absolutely. The initial nerve block is often done as a single shot, which means the needle is placed under an ultrasound probe and local anesthetic bathes the nerve bundle, and then the shoulder and arm kind of go numb and stay numb for as much as 16 hours. There are a number of kits available where one can use a special needle and pass a catheter, a long tube close to the nerve bundle, affix it to the skin, and then have a reservoir of local anesthetic, which can infuse over the course of 2 or 3 days. And that usually is the most painful part. And if you've managed to bridge people through that time, they can then move on to ibuprofen and acetaminophen for pain relief. Don't ever have to have an opioid.
Yeah.
I personally have had a right shoulder replacement and never took an opioid, either during the procedure or afterwards.
Yeah, because the regional anesthesia was so good. Now, once you withdraw the regional anesthesia and you're hours or days away from the surgery, the whole inflammatory response has actually slowed down a little bit. So theoretically, you shouldn't be in as much pain, right?
Exactly.
Yeah, that's a great technique. I've also seen some innovative use in general anesthesia for bowel preps to minimize the post-operative slowing of the bowels, using drugs like gabapentin and things. And I guess that's becoming much more common these days.
Well, it's true. Another approach is to use an epidural as part of the surgical anesthesia, and then it can be continued. An epidural is placing a catheter right close to the spinal cord, but not in with the spinal fluid. Then you can bathe the nerve roots as they exit the spinal cord and reduce the sensation. That also minimizes the use of opioids and increases the likelihood that the bowel will recover quickly.
Right. Well, this has been a great talk about surgery. I also just want to point out, and this may have not been your specialty for your training, but lots of anesthesiologists now are out of the operating room and doing actually chronic pain work, ablations, infusions of numbing medication, anesthetics plus steroids. And there's a lot of skilled anesthesiologists out there that are out of the operating room doing pain management, which is great. And I think it's also great that there's a general trend away from the use of opiates unless absolutely needed, which I think is going forward a healthy thing that's happening in the routine management of acute pain. Well, this has been a great discussion. It's been my pleasure to have you as a guest and also welcome you to the Medical Advisory Board of the Columbia Association.
Thank you.
Thanks to our audience for listening, and thank you to the Columbia Association for sponsoring Finding Your Wellness. You can listen to all of our podcasts from Finding Your Wellness by typing into your browser podbean.com/Dragon Podcasts. This is Dr. Harry Oken, again, for Finding Your Wellness.